Hello and welcome to the Pilates Hour. It's getting close to the holiday season. We're right in the middle of it, so I know everybody is busy and starting their travels. I am excited to be with you today and talking about a theme that I absolutely love. I love talking about low back. I've always enjoyed treating low back pathology and trying to figure things out because there's no two backs alike. While people are joining, if you'll do as usual, just do a little shout out in the chat. Let me know where you're joining me from today. And always like to see some familiar faces. I see Lisa Leader on from DC. Hope you're doing well, Lisa. And just lots going on, isn't there? So the world's being a little crazy. At the same time, we're trying to celebrate our holidays and to find joy and peace. So wishing that to everybody, even in these situations that are around the world. So as we get started, let's go to our first slide. I sort of want to run through some of the mechanisms of lumbar pain and talk a little bit about it because it can be incredibly complex. And anytime that, again, there's usually lots of questions when we talk about lumbar pain, especially when we talk about the disc. What does it look like? How do we know what's going on with it? So in the chat, like if you have been challenged with working with clients with low back pain, just sort of give me a thumbs up or something and let me get an idea of how many of you are currently working with somebody with low back pain or that you've had some challenges working with people with back pain, mainly because there's no two people alike, as I mentioned. And I'm just going to go through a couple different mechanisms of lumbar pain. A lot of times we talk about pain is a centralized interpretation of peripheral stimulus. So what that means in layman's terms is something happens in the periphery of our body, so our back, our skin, our stomach, and that message gets sent up to the brain, and the brain has to interpret it. And the brain has to be in a conscious state to be able to interpret that message. So typically it comes up to the thalamus. The thalamus will often refer back to other parts of the brain, the historical part of the brain, the parietal lobe, asking questions along the lines of, hey, do I need to be worried about these signals that are coming up from the low back or from my left toe? And the parietal lobe, depending on the history, would say, yes, you've had problems with that low back pain for years. And then it will send a message up to the frontal lobe of the brain. And that's where the cognitive processing takes place, that we interpret something as being wrong. Again, there is typically no, how should I say this? There is no direct correlation between the intensity of pain and the tissue damage. There are people who've had severe tissue damage with very little pain and vice versa. We also know that when we are anesthetized, when we are unconscious, or that there is a block that prevents the nerves from conducting to the brain, that there is no pain. Pain has to be experienced in the brain, in the frontal lobe, for us to be able to acknowledge that. So that's something I want us to keep remembering, is that there's not pain occurring in the disc or in the back or around the dorsal rami, but there are nerve endings that are sending messages to the brain, usually of warning. Now, some of those warnings are things about inflammation, for example. So the cytokines and different types of inflammatory products that our body makes are often what are creating the stimulus to the signals to go up to the brain. So let's talk about a couple of those. So when we look at the dorsal rami of the back, we're literally talking about the nerves that are coming out the right out of the side of the vertebra, or between the vertebra. So if I take my two vertebrae here and we take a look at them, again, we don't have to look too close, but when you look at the nerve root coming out the side of the vertebra, in between them is typically where we get some compression, irritation on that nerve root. That's the lateral branch, and we'll show a couple pictures in a second. So a lot of times, any pressure on the epineurium, that's the connective tissue around the nerve, or inside the spine, we often call it the dura, around the brain. It's the same kind of connective tissue. It's continuous throughout the body. That when that gets compressed, it's going to create an inflammatory response, and it's going to cause symptoms of pain. Those pains can be radicular, meaning that they radiate down the leg or down the arm if it's in the neck, and yet it does not necessarily mean that it is compressing the nerve root itself. It could be just compressing the epineurium around the nerve. And that's sort of a protective mechanism that the body naturally has. So we would feel pain down the leg, we might feel it down the arm, we might feel burning, or we might feel some tingling, paresthesias. Those are all things that we could feel as a result of irritation to that tissue. If there's pressure on the actual nerve, we're going to see neurological symptoms. Neurological symptoms would be things like weakness or loss of sensation. A lot of people confuse the word numbness with paresthesia. So if you can feel and we can touch the skin and they can feel that skin, or you take a pin and you prick the skin a little bit and they can feel that, that means that there's not a loss of sensory. But there might be paresthesia where they feel the ants crawling, or they feel pain in particular that is not necessarily representing compression of the actual nerve tissue itself. We also refer to the disc, right? So the disc gets blamed for a lot of things, but it's not always about the disc. What there is some very cool things to know is that when there is an injury to the disc, if there's a protrusion or a disc herniation or a disc rupture, the insides of the disc actually create what's called a chemical pain. They create an irritant on that nerve root. So remember how I said when that nerve root gets inflamed, that it's going to send signals to the brain, and those signals, depending on how bad it's inflamed, could be more severe or less severe of pain down the leg or pain in that local area in the low back. We also know that the outer ring of the annulus, so we're going to look at some of that anatomy in just a second, does have vascular and innervation. So when there is an injury there, you're going to see an inflammatory response, and you also have sensory nerves in that outer ring that could also provide a sensory response. So any injury to the disc does not necessarily mean that there is a disc herniation putting pressure on the nerve root. It could just mean that there is a disc injury, and in and of itself, it can cause pain. And sometimes that chemical pain, I've been told by some researchers, can last 6 months to a year. So some people are just dealing with that sort of chemical pain, irritation, and inflammation around that tissue. The referred pain, we talked a little bit about somatic referred and radicular pain. And both of those really are not necessarily horrible signs. A lot of times we get a little afraid of radicular symptoms. But when we see that, again, that it's a loss of power or a loss of sensory, we do need to take it more serious. So a lot of times you might be working with somebody in the Pilates studio and they have low back pain, they have some radicular symptoms. What we really want to know is, where do those radicular symptoms go to? Because that often tells us where the problem is. And do they have any loss of power? Like, is their foot dropped? Are they able to resist with their big toe if it's an L5, S1? Do they have quad strength, an L3, L4 level? So we can tell by that and by their reflexes if there is actual damage to the nerve root or if there's pressure on the nerve root. Let's go to the next slide. So here we look at it, and I like this picture because it sort of represents the wholeness of the nervous system. The nervous system is continuous, and it is the connective tissue around the nervous system that we see when we dissect. And that connective tissue, as I mentioned, in the central nervous system is referred to as the dura. And the dura is the protective sheath that surrounds the spinal cord in the brain. And then as it leaves the foramina of the spine, that foramina means hole, as it leaves the hole to the side, we call it the epineurium. So the epineurium and dura are synonymous, just different parts of the body of the spine, of the nervous system. This is why when you're sitting down, for example, one of my favorite exercises is to sort of test neural tension, that whole movement, is stomach massage. So if you're sitting on the reformer and you're curled over and you're holding on and your feet are up and you go into knee extension and dorsiflexion and you're keeping your body in flexion, you might feel a nerve zinger all the way through the nervous system. And you might find that lifting the head up or bending the knees takes the pressure off of that nerve root tension. And that's because it is continuous. So one of the things I always like to rule out when I'm looking at somebody that has a potential disc problem or radiating symptoms is looking at what we call neurotension, right? So is there a restriction that is putting pressure on the whole nervous system from one area? So we can test that, and we can, reduce it down to where we think the actual restriction might be occurring. And that gives us insight of where the injection might take place, or where the mobilization takes place, or where the Medrol pack or cortisone would be used to be able to reduce that inflammation and see if we can get movement in it. In chronic pain, often what happens, somebody that's had chronic low back and chronic radicular symptoms, is that their neural tension is positive, but it is old, meaning that there is scar tissue or fascial restrictions around that nerve. You maybe have experienced it sometimes when you reach your arm out and you take the arm down, right? And you'll feel like a zinger into your hand or into your little finger. Sometimes people have restrictions from fractures in their arms or their legs that have actually restricted that epineurium as it passes through those tissues. And that will in turn cause a excitation of symptoms when you stretch it. Nerves hate to be stretched. And I always like to remind people of it. They love to be mobilized. They don't like to be stretched. So sometimes we confuse things like hamstring tightness with neurotension. And it's very easy to differentiate. So if somebody's sitting on the edge of the trapeze table and we take them down into a little bit of a slump position and we have them raise their leg up and they say, oh my gosh, my hamstrings are so tight on that right leg, have them lift the head up or the back up, keeping the leg there. And if the tension in that hamstring goes down by lifting the head up, that is not a hamstring problem. That is not a myofascial problem there necessarily. It's more than likely a neurotension problem. And so we have ways of trying to mobilize that nervous tissue, almost like you're flossing your teeth, to be able to get that mobility to happen again. So when we look at this case today, we're going to look and take into consideration the mobility that she has in her nervous system, if there's any restrictions there. So here we get a little more detailed look at the rami and the dorsal root ganglia coming out of the foramina. So the foramina is the dark space in between the spinous process there that the nerve root is coming out of. And those nerve root fibers then are going into the bundle, typically in the lumbar spine, into the sciatica for the lower nerve roots. And then they will travel down the leg, and they will provide both motor and sensory. So what that means is that there will be nerve conduction to activate muscles, and there will also be nerve conduction returning to the brain or the central nervous system that are sensory. So they're picking up signs from the mechanoreceptors in the body. We know these things because of things like reflexes. So if you know with a hammer and you tap the patella tendon and the knee jerks up, that literally is a sensory neuron in the patella tendon that gets stretched, or in the quadricep muscle that gets stretched. It sends a message to the brain, and the reflex then sends a contraction back to that muscle and causes a contraction. That's why we see this reflex in about 50 milliseconds. A lot of our automatic responses are built just in spinal cord reflexes, so things like walking, swimming, things that are repetitive that we do in our bodies. So when we look at the injury here, you can see where the disc is. If that disc is injured and it puts pressure back towards you see the blue vein there, and you see the yellow nerve. So if it puts pressure back towards that yellow nerve, it might not completely block the nerve, but if it just puts a little pressure on the outside, that's where the irritation of the epineurium is going to be. So the yellow is the epineurium. If we cut that open, we look inside, we can actually see the nerve fibers. So pathologies-wise, when we talk about a disc pathology, we can think of 3 or 4 things. We can think of the chemical pain, as I mentioned. So just the mere damage to the disc can release and cause an inflammatory response around the nerve tissue. The second is the dura itself. If the dura gets pinched or the epineurium gets pinched, like a lot of times people with stenosis, if they go into extension, the space is already narrow, and they actually pinch the nerve. And they pinch that nerve, and it causes an inflammation, and that inflammation now is its own problem. The annulus innervation, that would be, we talked about that around the disc is nerve innervation, mainly sensory. And so when there is trauma to that disc, like we bent over and picked up something really heavy that was way heavier than we thought, and we actually tear a little bit of that annulus, right? A lot of people have minor tears. They have low back pain for a little bit, it goes away. They do another stupid thing, more tear, more back pain. until they finally have something that is more disruptive, like a protrusion or a disc herniation, right? So that annulus itself has its own innervation, its own nerves that can respond and can produce pain, and that pain will be interpreted in the brain, and the body will feel low back pain. The last one, and the one that we're sort of going to be looking at today a little bit, is a nerve root compression. So that's when the disc herniation is bad enough or the foramina is narrow enough that the nerve root is being irritated. And then the question comes, are we putting pressure that is actually causing neuropathies and weakness and loss of sensory, or are we just irritated that it's causing pain and maybe some radicular tingling and paresthesias in the leg? I'm not going to talk so much about the zygapophyseal joint, that's the facet joint, but just understanding that facet pain is like joint pain. So the facet is an articulating just like your ankle, your shoulder, your elbow, your wrist, your knee. And if there's a problem inside the facet where there's a damage or a fracture or some instability from the ligaments in itself, it also can cause an inflammation. And that inflammation, having the same nerve roots around it, is going to be coming up to the brain. The brain's going to say, look, in that region, something's going on and there's pain. So as a physical therapist or a physician, we have to sort of differentiate, is this pain coming from the facet just behind the spinal cord, or is it a nerve root dysfunction? They both can cause radicular symptoms. They both can cause local pain. So it's important to understand that we as doctors and physical therapists have to differentiate those particular signs and symptoms to see where things are coming from. Now, typically, a sprain to a joint will heal much faster and respond to things like anti-inflammatories compared to a nerve root irritation. A nerve root irritation might take much longer and require something like a Medrol pack or steroid treatment or even an injection to shrink the inflammation with something that has a little more power than just the anti-inflammatory non-steroidal drugs. So here we look at the combination of the disc and the vertebra, and we understand inside the disc is the nucleus pulposus. This is the jelly fill. As we age, I was explaining this to Melissa, who helps me and does just miracles of putting together the slideshow and the webinar in and of its own. But we were talking a little bit about how the nucleus pulposus, as we age, becomes drier and stiffer. So even, for example, in the cervical spine, there is a loss of fluid and jelly-like substance in the nucleus pulposus as we age, and we're less likely to have a disc herniation. We're more likely to have degeneration. And so in the lumbar spine, it lasts a little bit longer, that nucleus, and usually up into like 50s and 60s, you can still see a little bit of gelatinous material there. But as we get older, it does dry up a little bit. So one of our goals in Pilates is that motion is lotion. So if we are constantly moving that tissue, we're doing our roll-ups, we're doing our swan, we're doing our side bends, we're doing our mermaid, we're doing our spine twist, we're actually stimulating it to stay hydrated. The other problem we have is distribution of movement, or better said, lack of distribution of movement. If there is not enough movement at that segment, so we know we have 24 vertebra, 23 disc in those of us that have not had fusions, and the more that we move segmentally and in a safe range of motion, the more likely we are to keep our disc healthy. There was a train of thought for years that was to not do forward bending or forward bending with rotation. And so we gave it as a contraindication, especially to people that are aging, and we've used this contraindication for osteoporosis as well because of bone fragility. But for most of us as human beings, we need that segmental movement. We need that load, not only on the nucleus pulposus, but also on the annulus. In the annulus, the rings here, if you looked at and you dissected it, it sort of looks like our abdominal muscles. So you have some fibers that are going perpendicular and at an angle, others are going horizontal, others vertical, and the layers are made specifically for that. But as I mentioned to people, we talked about this a little bit in the mobility lecture last week, is if we don't load those tissues on a regular basis, there is no accommodation to the load. And so those tissues become fragile. And when they become fragile, they're more likely to degenerate or to tear when there's an abnormal load placed on it. When that doesn't happen, or we exceed the load of the tissue, for example, we picked up a box that we thought was lighter, that load could be transferred through and actually disrupt the tissues of that annulus and lead to a disc protrusion or a disc herniation in this example. And the nucleus pulposus moves towards it. So every time that you bend forward, every time you stand up, that pressure is continuing to press on that spinal nerve and that nerve root. And so that would then cause an inflammation of that. And whether or not it actually caused neurological symptoms or just some discomfort would just be a matter of how severe the grade is of that disc protrusion. So here's an example of an MRI of an L5S1 lesion. So we're looking at it here. The gray part in the middle on top of the red loop, that is the disc. And the little protrusion you see coming out, that is the disc herniation. And the really white, bright, sort of look like little dots, that's the spinal cord. Everything around it is spinal fluid. And if you look to the right of the screen, you can see some of the compression there on the nerve root that is coming out on the right. And so that gives you an idea. When we look at an MR, we want to know what is going on in there and how severe that disc protrusion is. So it gives us a lot of visibility. And we look at a axial slice of a disc herniation, and again, it's an L5S1, and you can see how the disc protrudes out. There's a little bit of a collapse of the height. Now, the important thing is look at the vertebral disc above, and you'll see how bright they are. That's the nucleus pulposus in the middle, and that it is still very much intact and very healthy. When we look down at the L5S1, we see a loss of that, and we see the disc protruding out into the space of the spinal cord. Now, if we look at the spinal cord here on the left, you'll see what looks like a horse's tail. We call it the cauda equina. And the cauda equina is the grayish, kind of whippy looking things inside the clear fluid. The clear fluids are the spinal cord fluid. And so a lot of times you can have a disc herniation with no symptoms neurologically whatsoever, even full disc herniations that are really putting pressure posteriorly because the fibers coming down in the bottom part of the spine are sort of wispy as they come out to the side. And so they can move around the disc. So you can see somebody has a very severe disc herniation and not have any radicular symptoms, or they could have a little disc herniation out to the side that actually does put pressure onto the nerve root coming out of the foramina. So the MRI should be compared to the clinical signs, not to just treating the MRI. And I can talk a little bit more about that later. But the goal is not to put a lengthwise stretch on it. So we call it like flossing. So if we move, our head might be moving opposite of it. So it's like you're pulling the floss through your tooth rather than stretching the floss. And in muscles, we often think of myofascial. We try to stretch it apart, where in the nervous system, we're just trying to move the nervous system through the sheath, right, through that epineurium. And we'll take a look at a little bit more of that. So role of movement practitioners and therapists. When we're looking at acute low back pain, and we're trying to differentiate whether it's discogenic or whether it is radiculopathy or whether it is a facet problem, one of the best things we can do as Pilates teachers is to teach them disassociation of hip mobility from spine mobility. What that means is that, do you have movement in the hip without having the sort of almost reflexive movement in the spine? So if the knee comes up towards the chest, does the spine automatically go into flexion? And if the knee goes in or hip goes into extension, does the back automatically go into extension? And one of the nice things that we teach, even starting on the reformer, maybe some mat exercises of some bent knee opening or dead bug exercises, is to disassociate at the hip. So what that means is, let's create movement at the hip without it having to cause movement in the spine in this early stage of rehabilitating or re-educating individuals with back pain. Now, this is really, really important. This is something we noticed very early in the Pilates research, was that if we could teach them a little bit different than the normal pain strategy. So I don't know if you had back pain before. 95% of us will have back pain. 25% of us will have back pain for the rest of our lives. But if you've had and been somebody that's had back pain, it's very interesting that as much as you think it would be normal to move the hip flexion, we tend to strategize to stiffen everything up and hold our hips, squeeze our glutes, and our movement then comes from the segment that's damaged or injured. It doesn't quite make sense to me why we naturally do that, but we do. And so what happens is it's one thing to damage that disc and have a little bit of inflammation and irritation around that nerve root. But if every time we move, every time we get out of a chair, every time we roll in bed, every time we stand up, our strategy is, again, irritating that one tissue segment there, then it's never going to heal. The way I compare it is if you had a cut in your hand or a cut on your arm, and every few minutes you open the cut to see if it was healing or not. What you're doing is you're disrupting the healing process. In the low back, this is a strategy approach. What we're saying is let's change the strategy so they really learn how to move from their hip and pelvis and not always from their lumbar spine and the lumbopelvic movement. So how do we do that? Think of those things as far as, footwork on the reformer, nice movement going with the pelvis staying quiet. How do we do that on the chair? Maybe single leg pump, standing up, pelvis is quiet and vertical, the leg is coming up and down in the pumps without the back going into flexion. If we can teach that concept of disassociation, that's probably one of the most powerful tools we have with acute low back pain. Deep breathing exercises. Wow, we cannot go wrong with deep breathing. Deep breathing often hurts when your back is acute in spasm and you try to take a breath. Sometimes the back will seize up with it. Get into a comfortable position, maybe gravity eliminated, and use breath to be able to negate the effect of the spasms and to truly try to relax those muscles around the rib cage and particularly the quadratus lumborum in the back. Graded axial load. These are things that we look at to where, for example, what I showed you with that nerve encroachment, that nerve pinch, is that standing up is going to be painful. So they might be comfortable laying down or sitting down, but standing up is going to be a problem. Well, for us, we can grade that axial load. Axial means our orientation to gravity, being standing or sitting. How do we grade that load back to something that resembles normalcy for somebody who has a lot of pain when they stand up? And then we gradually introduce movement with non-destructive forces. So I think of exercises like, pelvic clock, or a little bit of oscillation into anterior-posterior tilt while laying on your back. There's not an axial force. There's not a gravitational force. The movement can be very minor, very gentle, but that allows to start introducing movement and getting rid of the strategy of compensation of all the large global muscles of the back and the trunk. If we can get those to relax and wake back up those deep local muscles like the multifidi and some of the stabilizing muscles deep in the trunk, we're going to have a lot less stress and a lot less pain. And then the last thing I always think of as movement practitioners and therapists is the patient has to embody the behavior change. So if we teach it to them 2-3 times a week, but they go home and they revert back to everything moving from the lumbar spine, then we didn't do any good for them. So no matter what we do, we're always going to have to give them some kind of home programs. Every time you go to the bathroom, try this. Before you get out of bed, do this. When you're feeling a little discomfort, get down on the ground or on a table or somewhere that you can get down on a hard surface, and let's work on some disassociation. Giving them little things to do every couple hours to be able to start decreasing that muscle guarding and that muscle spasm that are all protective mechanisms for those problems. I see a question came in from Irena French. It says, does disc prolapse ever heal and get back to its original form? Now, there is a good study from Japan that looked at a ton of MRIs and followed them over time. And they actually showed that there is, because the nature of the disc is to degenerate as we age, that prolapse, the amount of prolapse actually does decrease. And that's why as we age, we see less and less disc pathology and more stenosis and arthritic changes in the back. So our goal is try to keep the healthy disc as much as possible, prevent those injuries, distribute motion. But in the case that we did have a disc hernia, it could take years for it to reduce. Or, of course, there is surgery or injections that often can maintain or decrease the problem in the here and now, but then it leads to problems in the long term. So anybody that's had arthroscopic surgery of their knee or shoulder know that 20 years later, 30 years later, they have some pretty significant degenerative changes. The surgery allowed you or me to continue our sports activity for all those years, but eventually it catches up to us anytime there's a joint invasion. So again, if we can avoid surgery, we do. I sort of have a rule on surgery too, and Irena, you bring this question up. If in the spine, if I don't see hard neurological signs, it's just pain, I'm pretty much anti-surgery. I'm okay with injections and steroids, but I don't think that surgery is a good fix for something that doesn't have a hard neurological sign. Like if they don't have a loss of strength, a loss of reflexes, a loss of sensory, I'm thinking that we might be in it for the long haul, but we just have to create some behavior that decreases the load on the tissue that's been injured. We do that with Pilates by getting more segments of the spine to move, getting the hip to move. We refer to that in the mobility as distribution of movement equals distribution of force. And then Irena also asked the question, what is HEP? I apologize for using abbreviations. Shelley always hits me in the head when I use abbreviations, but that is home exercise program. That's something that they're doing at home on their own. So thank you for asking that. So we're ready to go into the case, and you guys are going to help me with this. So make sure that you have your devices ready to go into Mentimeter. Maria is a 38-year-old female. She is a dance educator at a local university. She recently found a passion for cross training, which is a little different load than what she experienced with dance. So she has lots of flexibility, lots of control, but not used to dealing with load. She also enjoys playing the piano, which we do sitting down, is married, has a 1-year-old son, 3 years old, which you can imagine is probably about 40 to 50 pounds, probably still likes to be carried by mom. Maria was diagnosed recently with an acute disc herniation at L4, L5, and the symptoms are on the right side. While we're doing that, Catherine Connor asked a question. As a Pilates instructor, dancer with back issues, everything you are saying I can relate to and I'm able to incorporate into my teaching. Oh, I'm so glad to hear that, Catherine, because I do the same thing for myself, and a lot of us got into Pilates because of dance injuries, sports injuries, running injuries, and we found that we get our best relief in what we teach. And if we practice what we preach, we often get better. Another side note on that Catherine brings up is when we have people applying to become Pilates teachers and they want to do the program. And sometimes they'll say things like, I have a disc herniation at L4, L5, or I have this, or I have that. And it's sort of like our language to them is to encourage them. It's like, this is your cure, is to do the Pilates, to re-educate your body. And so if we're doing our practice right and we're teaching the right thing, you should be able to go through this training successfully, maybe with a few modifications, but understanding that what we're teaching is helping you in the way that you are going to help other people in the future. All right, so if we go into the patient interview and ask Maria, what do you believe you should be able to do? She wants to be able to teach, she wants to be able to work out, she wants to be able to carry her 3-year-old son, bend over to dress, bathe, and other daily activities. And because she's not able to do those things, if you ask her, she says, I just can't bend, and lifting causes moderate to severe pain in my right buttock and sometimes down to the back of my calf. It causes zinger when I bend or carry any additional weight. So she's giving us some really good information right away that there is something going on that is causing these paresthesias. The zinger is a paresthesia. Some of the symptoms down, right buttocks pain, quite common with some kind of disruption in the low back. What would you hypothesize Maria needs from us first and foremost? What are things that you think she needs? Remember when we said that she is a ballet teacher at the university, teaches dance, modern dance, ballet, also just recently started with her cross training, which I find very interesting and very good. I mean, we love our dancers to do cross training because we feel like it can prepare their tissues a lot better to be able to dance longer. Anytime you have a very biased training, your tissues get biased to it. So I'm glad that she's cross-training, but she might have overdone it on the cross-training, being that she's flexible. Now she's creating a lot of load with the weights and the different types of cross-training. All right, keep those answers coming in. And remember that she is talking about having discomfort with either carrying her 3-year-old son, having to move too much, axial load, standing up, carrying things, bending forward, rotating. You can think of like putting on her shoes or cutting her toenails. She's not able to do that right now. That's causing her a lot of discomfort. So I see some things coming up, knowing she could move without pain. So I would say first and foremost, whoever wrote that, that's my number one goal, right? It's not pain relief, but it's creating the positive movement experience without pain. So I try not to focus on the pain. I don't ask questions like, where does it hurt? I'll ask, what are the symptoms that you're feeling? Can you explain them to me? What does it feel like? What makes it better? What makes it worse? Without ever using the word pain. And then my goal is to create that successful movement experience without pain. So what kind of things come to our mind? Like, how do we start restoring her to some of her functional activity? Right now, acute low back pain, radicular symptoms, pain with compression, pain with flexion and rotation on that right side. So I see some good things there. Support and glute strengthening. We're going to need to find some control, and we're going to come and look at that and see what her overall control strength is like on one of the future slides here. All right. Anybody else want to add a few more? Making sure she can find a position without pain and then help her do some small movements. I like that. Build up the better pattern of movement, find what movement position doesn't hurt, look how she lifts her child. Good. So looking at strategy and behavior. Absolutely. So next question, what activities will Maria need to be able to perform successfully without pain to function successfully at home, work, and recreation? And this is very much a part of our critical reasoning processing. I can't emphasize it enough that we as Pilates practitioners really need to have good critical reasoning. There's nobody that's coming in that is without some kind of limitation, restriction, or problem. Even if they're super healthy and active, we're going to find imbalances. That's sort of our specialty. And then to try to help them improve those balances, improve their function. So the big question to me always is, what activities do they need to be able to return to? What activities did she say when I asked her what she could participate in and what she's not able to participate in? Because those activities are going to dictate what Maria has to be able to return to be functional and to be whole. For her to believe that she is healthy and that she can return to her daily life, what activities does she need to be successful with? Let's get some answers in there. And if you haven't gotten on yet, give it a try. It's sort of fun. It's anonymous, and you can guess and see if you're coming close to what other people are saying. Here we go. So we have flexion, side bending, taking care of her son, and dancing. So you can imagine the load that dancing would have, right? If she teaches modern dance and ballet, if you're thinking of things like passe développé with that right leg, often takes you into a little bit of lumbar flexion, bending down to pick up her child, bending and lifting. Good. Those are exact kind of activities. Walking, rotating, bending forward. Needs the ability to reach down without pain. May need another way to do it, right? So I know when I've had like my hip surgery and I had to be careful for the first couple weeks to a month, it was like finding new strategies or shoes that didn't need to be tied or things like that to be able to minimize the exacerbation of those symptoms. What that means is, another word is perturbing, like you're irritating it. Every time you flex that spine when it's an acute inflammation, we're just making it worse. We just keep opening up that wound. We keep making it worse and worse. All right, pick something up off the floor, squatting, flexion, rotating. Kizik brand makes no hand shoes. Oh, yes, Kizik brand. Thank you. I'm going to look into that. I am actually going to have my left hip replaced in a couple weeks. So when I come on to the next program that I'm doing in January, I will be with a new hip, and we'll be just talking about, it'll be a little selfish on my case, but we'll be talking about my hip and my hip replacement and seeing how we're doing 2 weeks after surgery. So the physical presentation, she comes to, let's say, me as a physical therapist. I want to know sort of what The physician sent her to me. Maria presents as a slender, active woman, favoring posture and weight bearing on the right leg, which would make sense. She doesn't like putting pressure on that side. Her gait pattern also shows poor tolerance to weight bearing on the right leg. Medication, she's taken a Medrol pack. That's a steroid pack where you take 6 one day, 5 the next day, 4, 3, 2, 1. And that intense burst of cortisol or prednisone actually decreases inflammation if it really is a nerve root problem or a disc problem, and can often provide really good relief pretty quickly. Other findings, her reflexes and sensory were normal, so there was no hard neuroscience. Strength in the leg is normal. She had a positive slump test. So when I had her sitting on the edge of the table, lifting her right, straightening out her leg with her head down, brought the pain on. I had her lift her head up and the pain went away, head back down, pain went on. So we know that there is a neurotension component to it. So I want you to remember that as we progress her in her exercises and she's feeling better, how do we make sure that she doesn't have that neurotension that she really can't have as a ballet dancer, modern dancer, mother of a 3-year-old. She has to be able to bend down, even in just basic dressing. Right side bending provokes symptoms in the buttocks. So if she bent to the right side, right, we said that's where the problem was, that side bending. She could feel the pain into her buttocks and a little bit down her leg when she came for physical therapy. So here we go. A month after physical therapy, the radiating pain had diminished. There's almost no radiating pain into her buttocks or down the leg. Posture and gait have improved significantly. She continues with poor tolerance with bending and with carrying the weight still irritates her a little bit. What I realize as a therapist is that she really needs to start doing Pilates 3-4 times a week. And so I want her to go to the Pilates teacher. And I'm asking the Pilates teacher to focus on improving mobility of that lumbopelvic region so that she can bend and perform her daily activities, and also the hip region. She's still having some restriction there, and I don't want to diagnose it prematurely, but I do think that she has some degeneration in that hip, which is not uncommon with ballet dancers, even that young. Gradually increase load tolerance, so I want to do a graded load program for her, and then the goal is really to get her back to dance. And I feel like you as the Pilates teacher are going to be the most successful at those 3 things. If we understand what we're dealing with. That regular Pilates intervention and the things she's going to be doing with you as a Pilates teacher are really going to be beneficial for her and are going to be the main thrust of getting her back into her normal daily activities. So I've given you a couple options here, but what would be your first assessment choice? You can mark a couple of them if you want, because a number of them are good ones for us, but just take into consideration what we found on the 1 month after. So we're saying this is 1 month after her physical therapy. She is being referred to you as a Pilates teacher, and you want to pick a couple of either the Polestar assessment test or the screening test, or maybe your own test, right? But just identify which of these do you think would make the most sense for her. And let's see how you guys weighted out on the 5 possible tests that I put up there. This is not exclusive by any means. This is just looking at based of what we saw with her. So just sort of curious what you think would be the most important ones for her. Right now I'm seeing some nice division in there. I think that's good. I see squat, lateral flexion, and swan are pretty heavy. That's great. Plank and roll up are picking up. Very good. Let's get a few more in there. See if we can get a few more of you to participate and play the game. And again, because it is anonymous, nobody knows who's putting what in there. Let's go for 5 more seconds. 4, 3, 2, 1. All right, so I see squat, lateral flexion, then swan, and then a crossover between plank and roll up. Let's go to the next slide. So I picked the squat, the lateral flexion and sitting, and then the plank. So we're on the same page, and there's nothing wrong with the other ones. They're all good tests. These were the ones that I picked. And when she did her half squat, she was able to do a half squat with no symptoms. But as she progressed into full squat and had a little bit of flexion, right? What it looked like to me was she had a little bit of loss of ankle dorsiflexion and hip flexion. So as she was going down into the deeper squat, her back went into flexion, and she noted some discomfort with that. So that makes me think, if I can get a little more hip mobility, a little more ankle dorsiflexion, I could take away some of the lumbar flexion right now. So that could be a really good adjunct, sort of making a mental note of it as we're going to work with her. The lateral flexion in sitting, full side bending to the left, at the end of the range to the right. So she had pretty good side bending, but that's where she felt the discomfort, which would also manifest in rotation to the left. So right side bending, left rotation. If you remember last week, we talked about Fryet's law, where rotation and side bending happen in opposite directions in the lumbar spine, that we could see that making sense. So left rotation, right side bending, still irritating her a little bit at the end of range. Not too bad. That means things are calming down. But we also want to be careful that we're not going into that end of range in her exercise activity. That we don't want to go into the painful zone. We don't want to keep perturbing that area. And then I wanted to see what her stability was like. And I had a choice of either doing load, like having her carry a weight, or possibly to do a plank in kneeling. I had to do it with knees first, but looking at her plank to see if she was able to sort of contract that control of the muscles around the torso, if she had that relationship. And she was not able to hold that position. So there was significant weakness, did not have discomfort with it, but definitely weakness. And so that made sense to me of why she probably didn't tolerate carrying load in the axial skeleton. She didn't have that good connectivity around her pelvis and her low back. I'm looking to see a couple questions that came up in the chat. It's a little harder for me to read. But Amy said, as a dance teacher, we have a tendency to demonstrate movements on only one side. I'm so famous for that. I only want you to see my good side, right, Amy? We need to remember to alternate which side we are using. And that's a great thing, is looking at anybody participating in activity, always compare it to the other side and see what's happening. Because we have a strong side, we have a demonstration side, we have a weight-bearing side. Jillian said, I see a lot of issues with dancers and lack of dorsiflexion in Taylor Glide. How much does this contribute to back problems up the chain? Jillian, if you've listened to any of my webinars, you know how much of a fanatic I am about the idea of that kinetic chain, right? And we know that lack of ankle dorsiflexion does have a direct effect on that kinetic chain, whether it's the knee, the hip, the low back. There's a direct relationship with it. It's not hard to see. And I give you a good example. In the picture that Nicole is in here on the side, demonstrating the half squat, if I take a half roll and I have her put her heels on it, so I'm eliminating the dorsiflexion limitation, it's amazing to watch how straight the back stays and drops down into a beautiful squat with a lot of our people. We realize, the squat limitation was not a hip, it was not a strength, it was not a back thing. It was an ankle dorsiflexion thing. And then I'm going to take that a step further. A dear friend of mine in the industry, Eric Franklin with the Franklin method, I remember we were studying and doing some things with him back 20 plus years ago, and just understanding the bone rhythms or the arthrokinematics, and particularly in ballet dancers. When I took ballet, we were taught that we're spinning the pelvis, the femur, the tibia, the feet, everything's turning out, so we can have this beautiful turnout, the butt sort of tucks under, and then we'd go into a demi or a grand plie, and that demi and grand plie would not, we couldn't go down so deep. And one of the things Eric was showing us was that if you think of the arthrokinematics or the bone rhythms, and the femur spirals out, then the pelvis is spiraling in. So it changed the strategy. And one of the most significant outcomes of it was dancers who thought their heel cords were tight and they didn't have dorsiflexion, all of a sudden dropped down into a beautiful plie and started using buttocks muscles that they had forgotten about. So I would dare to say that a lot of the restrictions that we see from ankle dorsiflexion, especially in the dance community, could be induced by strategy. And if we change the strategy, we might find a little more movement. And that's something we'd want to think about with Maria here in this case. So what can we hypothesize would benefit Maria the most right now? So we're thinking we've done these tests, we've seen what she can do with her squat, we've seen her side bending, we've looked at her plank weakness. What are things that we think would be the most effective right now? So you're just getting her, she's a month out, no radicular symptoms, pretty much full range of motion, a little bit of pain at the end of it, except for flexion still a problem. What are you thinking? Where do you want to go with Maria? Let's see, I'm looking at, while you're answering that, Catherine put a comment up there, totally agree, and I remind students that most do have a dominant side, so very important to balance out movements on both sides and try to avoid favoring the dominant side. And this is very true, especially with gesturing sports like soccer, where you're kicking the ball. The more balanced your ball handling is on the field, the better player you are, the better diverse, the better your tissues adapt to the stresses. The same thing with dance. Anytime that martial arts is another really good one. And you see this in, for example, like with Tai Chi training. In Tai Chi, you definitely are doing things symmetrically, side to side. And when I take Tai Chi, I always notice the deficits of one side versus the other. And one side has maybe a little better movement of pulling up and reaching out, and the other side has better stability standing on. That's very common, and one of the things we want to do is to continue to try to load tissues so that they have sort of an equality of load and tension and compression so that myofascial system can adapt to it. Let's see what you guys are saying here. So strengthening, stabilization, love it. Neutral spine, stability, core control, upper extremity, weight bearing, stability, ankle joint mechanics. Somebody's reading my mind, my notes. Stability, mobility, build strength, overall mobility, control, axial load. Good. So we're all on the same page. And what I think comes up here is, it starts becoming clearer and clearer and easier for us to understand and interpret what somebody needs. And here's the kicker. Let's say that we chose ankle mobility as our primary approach on this one. And we work on it and we notice that it doesn't really alleviate her. Then we just go to the next thing that we talked about. We talked about maybe getting some core strength, or we talked about improving her hip mobility. What we want to do is we know what activity she needs to return to. We know that already. So our ability to find the right test and measures, and then we test our hypothesis of what we're going to work on. This is the critical reasoning part. This is what I love to teach. So what do we pick out of all these things to be able to move forward with it? So what can we hypothesize? This is what I put down, right? So I want you to see how I'm thinking after you put down what you're thinking. You're the vulnerable ones here. But increased trunk control. So no doubt that weakness she showed me immediately made me think she does not have that integration between the trunk and the pelvis. And she was attempting to go into cross training, and she didn't have that connection. And even though she had that beautiful aesthetic line in vertical as a dancer, she did not have that load integration of the torso. And I always like that to be very spontaneous. So if she's not, you think there's a big difference between moving your body through space and then picking up a 30-pound kettlebell and swinging it up over your head between the legs and, doing burpees and jumping down and up and down. All of those exercises, I think, are incredibly good. And I will give you a little heads up. Our colleagues, Blas Chamorro and Juan Nieto and one of their colleagues, and also Akin Sachi out of Turkey, are building a cross-training curriculum that we're very interested in that really continues to fill the gamut of human rights to move and our ability to really strengthen. But the beautiful thing is that it ties into the Polestar principles, and it really is looking at how do we create those graded loads so we avoid the experience that Maria had. How do we test to know if that core control is enough for her to be able to lift that 30-pound kettlebell and to swing it through the air? So trunk control. Number 2, instruct to be active within her neutral zone. Let me explain that. The neutral zone is basically the range of motion that is maintained with the most efficiency as soon as injuries happen outside of the neutral zone. So in Pilates, distribution of movement equals distribution of force. By having 3 or 4 more segments move in the spine, we keep her L4, L5 in a very safe zone that's not going to get hurt. And then third is gradually increase her neutral zone as tolerated, so as she heals, we continue to load, we continue to move into the range of the motion she has to do for her activities. Goals and objectives. What part of the body should be our primary focus as it pertains to restoring mobility, to increase her function and tolerance right now? Let's go a little quicker on this. I do have a couple comments in here while they are answering questions. I see Irena said aerial sports like hoops, silks also falls into it. We are always asked to do everything on both sides. And I'm so fascinated. I had a chance to work with Cirque du Soleil for a little while and to do some consulting and with their practitioners and as well as the performers. And it's just amazing at what their body had to be able to do and the symmetry and asymmetry that they had to be able to do. They definitely needed tissue adaptation. And then Irena French also asked, would any stretch help her? And, when I always train flexibility and strength or power simultaneously. So that's sort of how I think Pilates is meant. She's going to get flexibility benefits as we show control. This would also go into what yoga talks about with the co-contraction or the bandhas, that there is a balance between the tension and compression of the myofascial tissue around those joints. And as we have more and more control, we actually get more and more flexibility. They sort of go hand in hand. Great question. I also saw Samandi said Feldenkrais is very strong technique, like one warm up before Pilates class. And again, Feldenkrais, Moshe Feldenkrais, I included him in my new book and some of his philosophy because it is so powerful. It is an exploration of possibilities of movement. All right, so I see a lot of torso, a lot of pelvic and upper body organization. Let's go to the next slide. So again, my mobility idea, and I've already mentioned this, I gave this away a little earlier, but getting a little more ankle mobility, a little more hip mobility, a little more thoracic mobility are going to decrease the load in that neutral zone of the L4, L5 that's injured. So my goal is sort of reverse psychology. If I can get a little more movement in the thorax, I get a little more movement in the hip, a little more movement in the ankles, then she's going to have more suppleness in and throughout her range of motion. And you'd be surprised, especially in ballet dancers, how little mobility they have in other segments of their spine. And so it's one of the things, they have so much mobility in their hip quite often that they don't really have the mobility distribution in their spine. A modern dancer, a little bit different. And then people performing on silks and aerial, even more, a lot more segmental movement. They have to have it. Same with martial arts. So what modifications will you possibly need to make to create a positive movement experience for Maria? Where are we going to go with that? And I know I'm 4 minutes over, but we're going to finish this one anyway, so we're just about there. What modifications would be possible they need to create so she has that positive movement experience? Yes, that's what I'm hoping everybody's going to say. Because of time, I'm going to move into the next slide that has my answer on there. Decreased range of motion, like says perfect. Load and position, yep, we're on it. So limited load movement in her neutral zone is tolerated. Gradually increase her neutral zone and be thinking of tissue adaptation. So we want to go to ranges where she can feel the load, but not discomfort, not pain. But this is just a good example of some exercises that I would do with Maria. Starting off just with some breathing exercises on the mat, inhaling, exhaling, things that she can do at home. 90-90 on the trapeze table, great disassociation exercise. Footwork with distraction. So I have a special belt. It's a traction belt that we made that we put around the waist, and it has a spring that comes down below the foot bar. So when she's pushing out on the foot bar and loading her back, we're unloading the L4, L5 with a traction belt. So it works great to start building her confidence back up to be able to load and do movement with her legs while we're doing distraction of the low back. Long springs strapped around the thighs instead of on the feet. So remember that neural tension. She's not going to tolerate that real well yet. We'll progress her there. Bridging with assistance. I use that same sling up on the trapeze table so that she can have assistance in the bridge without having too much discomfort or getting cramps in the buttocks. Wall squats with the ball, dead bug, quadruped mat exercises, pelvic clock, all for home exercises. In the progression, we still continue with that 90-90. That 90-90 is something that just can eliminate a lot of the muscle guarding. So it's a very powerful exercise in the studio to get somebody to let go of all the global spasms and guarding that they have. Now, footwork without the distraction, feet in straps with on the feet, bridging on the foot bar, getting a little bit more height, quadruped on the reformer, leg springs assisted, breathing on the trapeze table now. So really working on that idea of long legs, rolling up, rolling down, single leg pumps on the chair with that standing disassociation, hopefully a little more core control, and then pelvic clocks for home, dead bugs for home. So that gives you a good idea of these are just samples of, hundreds of exercises that we have that could easily be modified in that very early to create that positive movement experience. And then if I was to go on to something more advanced, getting her closer to dancing, we're in standing work, we're in downward, we're doing the elephant and other exercises that are going to resemble the type of work that she's doing in her dance education. All right, let's close this session down. Thank you, everybody, for participating so much. I do want to remind you of a couple things coming up. One, our friend Wojciech, who was one of my guests with Zoga, looking at the myofascial and movement. He is actually in the United States teaching December 16th and 17th in San Diego, and then again January 6th and 7th. We are also hoping to host him in the future here at the farm. So that's some cool things with Zoga. So we'll send you the link for that. Also, I am going to be presenting the critical reasoning course again once in Dallas, Texas area. That is going to be in February 2nd and 3rd, and then again in New York, the critical reasoning course. It's a 2-day course in person with some live volunteers. That'll be March 15th and 16th. So just want to wish you all a very happy holidays and to take the time to reflect on those things that are most important to us. And above all things, be kind and have a wonderful Christmas and holiday season.